So we brought together two of BrightView's subject matter experts to walk through each type of treatment program. Dr. Cheryl McClain is BrightView's state medical director for Kentucky. She double boarded in behavioral health care, and she is a licensed clinical social worker with much experience across treatment, clinical supervision, training, and leadership in outpatient, inpatient, and medication-assisted treatment. She's passionate in supporting quality care for individuals managing their addiction and behavioral health needs. And with that, I'll let them begin.
Well, good day to everyone. Pleased to get the opportunity to share this information with you today and present alongside Dr. McClain today. So welcome. Just to look at our agenda today, we are going to do just an overview of the different types of addiction treatment programs that are out there, including inpatient, intensive outpatient. We'll also look at outpatient in terms of in-person programs and virtual programs. And then we'll also just talk about some of the differences and commonalities between those different programs. We have a few examples for you of patients transitioning from intensive outpatient to outpatient, real life BrightView cases that we're going to share. We have one of our therapists at our London, Kentucky center. She is going to be joining us and sharing those wonderful success stories later in the presentation. And then finally, we're also going to look at just helping you to determine what the best option for treatment may be for the individual that you're seeking treatment for. And then at the end, we'll have a few questions and answers as well.
I ditto what Rhonda just said. It's always a pleasure to present with Rhonda and to this group. So we appreciate you taking this hour during your lunch to sit with us and allow us to give you some insight into today. Will be some different programs that we're going to discuss. Happy to have our therapist with us as well, and we're going to clue her in a little while. She'll be a part of this. So in talking about programs, how do we decide? What do we think of? What are the criteria, different stuff? So that's what we want to give you kind of a bird's eye view as we go through this. Just know one size doesn't fit all. When we talk about the criteria, it doesn't mean you have to fit every single criteria. As a matter of fact, probably will not. And so when we talk about programs, we think about inpatient. We think about intensive outpatient program. We're going to really focus on that during this presentation. And then we think about outpatient. So that's your in-person versus your virtual. Virtual is the same thing as telehealth. That's where typically you're at home and you're joining via your smartphone or computer. We're going to go through all these programs, and then we're going to have a couple of case scenarios as well. Remember, there's no one single approach to recovery. Every individual has their own recovery path that's going to work for them, and it's our job to help them figure that out. So understanding the different types of addiction treatment programs is going to make it easier to help that patient choose the one that best meets their needs and what they're looking for. So as we go through this, we're going to help define that and talk you through it.
So let's get started first and foremost with inpatient programs. Inpatient programs are, of course, one of the more intensive levels of care available for treatment. And so with inpatient treatment, the big difference between inpatient and outpatient, one of the differences rather, is that the individuals will actually reside in the facility. So they're leaving their home, they're going somewhere to stay, and most importantly, they'll be receiving round-the-clock care and support. That's a very structured environment. And so the purpose of inpatient treatment is for that individual to go there for a certain length of time to stabilize. And so we'll talk about this a bit further as we go through the slides, but individuals needing inpatient treatment are usually in the most severe state of their addiction, having those needs that mean they need that structured environment and that round-the-clock care. Choosing this one may be an option as a level of care appropriate for individuals, again, who need that focused care, and they may need to leave their home to remove any triggers or temptations. One of the things that we'll talk about in just a minute is individuals who don't have good support in their home, or perhaps are living in a setting where other individuals are using substances. Inpatient may be a level of care to consider for them. Additionally, by going into the inpatient setting, they're able to get support from peers, individuals who are in that same program with them, going through the same thing at the same time. And then most importantly, that's a controlled and safe environment. Something to consider for individuals going into inpatient, they're not able to leave until they're released, unless they, of course, check themselves out of treatment early. So it is very structured and restrictive in that way. Again, just some examples there of individuals who may be a good fit. I did mention to you that folks with more severe addictions can consider inpatient treatment, as well as those with limited support in their homes. A few other things there that are important to highlight. This can also be a good level of care option for an individual if they've been trying treatment in an outpatient setting and that's not been successful after multiple attempts. It also is something to consider in terms of an individual who has a co-occurring need. Mental health needs can be common with substance use, and so individuals that have other conditions like depression, anxiety, history of trauma, any of those mental health conditions, this can be a good level of care to help them also stabilize those conditions as well. And then this biggest thing to think about with inpatient programming is this does, remove someone from their home setting for a period of time. It may be 30 days, it may be 45 days, could be longer. Some programs may go up to a year in length or more, just depending on the different programs that you're looking at. And so we're going to talk about different levels of care in just a minute, but just in summary, this is the highest level of care. And one of the things we'll talk about later is the importance of transitioning from this level of care into a lower level of care versus just going home with no supports. I'll hold on that since we've got that for you later. Intensive outpatient programming is the next level of care. This is a little bit less restrictive than inpatient programming. One of the things to consider with intensive outpatient programming is that the individual is able to be back in their home again. So it can be common for a person to leave an inpatient program and then step down to an intensive outpatient program. Essentially, after being inside a facility every day for a number of days or months, stepping down to this intensive outpatient can be a better level of care for them. So this is a little more flexible than the inpatient option from the standpoint that they are in their home. And one of the things to consider here is just the time commitment. So in the inpatient program, the person is there 24 hours a day, 7 days a week. In the intensive outpatient, or IOP, the person is coming into a facility for outpatient services 9 or more hours a week. Those 9 hours are typically divided into 3 3-hour sessions per week. And so this can be a good option for an individual, again, after stepping down from inpatient treatment. And this is, obviously a little less disruptive than leaving your home for an inpatient treatment setting. This level of care is appropriate for persons who, again, they've tried the outpatient level of care. They've maybe not made the gains that they need to. They've not been able to maintain their substance use being reduced or restricted, and they're continuing to struggle. This also is a helpful option, again, for individuals if they have a stable living environment or some support in the home. Maybe they're living alone, but they have a few sober supports. Intensive outpatient can be more successful when that's occurring. And of course, the intensive outpatient programming can also help them with gaining additional supports, which is so needed. Dependable transportation is something that would be needed for an intensive outpatient program level of care. just from the standpoint that that person, again, they're going to be in their home, they're going to be coming into that center or facility, usually 3 days a week, 3-hour sessions, so driving back and forth. And then lastly, even though this is more time consuming than the outpatient level of care that we'll look at in just a moment, the intensive outpatient program is doable for individuals when they're still continuing to work, to parent, engaging in their day-to-day lives. Typically, these intensive outpatient programs are offered at the start of the day or the end of the day. So that person is able to make that work and fluctuate, of course, their other responsibilities. Now I'll hand it over to Dr. McClain to talk about outpatient.
Thank you, Rhonda. So outpatient, we have in-person. That's what we think of typically when you think of outpatient. That's on-site. It's typically that person travels to the same clinic every visit. Those visits generally start out weekly, and then as you advance in recovery and progress, they'll go to bi-weekly every 2 weeks, and then finally monthly. So why would we choose this? Well, it's in person. That builds the relationships. It builds a community. You've got multiple people on site, and you can have some community and talk, with other people. You're not isolated. You've got some colleagues, and you're joining in even with other patients, for example. So it helps to increase your comfort level and hopefully the progression of your recovery. It's also cost effective when we compare it to inpatient, probably a little bit less cost as well than the IOP. And you're able to maintain your daily routines. It's less disruptive than the ones that Rhonda went through, the inpatient or the IOP. Who is a good candidate for this? Well, patients who typically live in a community that has a clinic nearby. Typically, hopefully, consistent transportation. Certainly, this is one of the obstacles that we face with this vulnerable population. The work schedule will permit them to come on site. There are clinics that do have late hours or early hours to help accommodate the work schedule. These patients are typically mild or moderate, certainly can be severe if all the other options are not available to them, but typically the mild or moderate symptoms of substance use disorder. They're highly motivated, and we would prefer on-site, again, with all those positives that we discussed earlier. This patient prefers in person. And generally, you have access to on-site ancillary services such as counseling, peer support, case management, some of those things that Rhonda had mentioned. And it helps to improve the recovery and the progression there. What's an option? We can go to that next slide. If some of those other criteria are having difficulty, for example, with transportation, then there's the virtual treatment option. What's that? It's also called telehealth. You've heard of this. It became very widespread during COVID, and many services went to that, not just addiction treatment, but also primary care, many ancillary services as well, counseling, case management, peer support can all actually be done in this fashion as well. It's conducted remotely using the digital technology such as your smartphone, your laptop. Basically, it's a video, much like what we're doing here. Why would we choose that for a patient, or why would a patient choose that? Well, it's more efficient, particularly if you're having some difficulty with travel and transportation, as you can do that from your home. You can also do it from a local clinic as well. Say you travel to a clinic on site, there's not a provider that you want to, that is there taking care of the needs that you have to be taken care of. So that's an option as well. creates flexibility and provides multiple modalities. It's much less disruptive in your daily routine. And many times, if the patient is immunocompromised or there's not a safe condition to travel. For example, maybe they've recently had surgery or they're disabled for some reason, this would be a great option for that. So again, to kind of sum it up, who's a good fit for this telehealth virtual pathway? Patients who live in rural areas or are long distances from a nearby clinic. The patients who are having difficulty with work related and do not have the time during business hours to travel, but perhaps they could do a telehealth visit over the phone and their smartphone during their work lunch hour. They have inconsistent access to transportation. That's very common in this vulnerable population. And that is very helpful to have this, again, flexible opportunity. Typically, this is tended toward the self-motivated. It's much less, it's easier to be disengaged if you're not on site. So this patient would be very self-motivated and want to attend, want to engage in their program. And obviously would have to have a very dependable Wi-Fi technology. So that's very, very important and can be an obstacle, unfortunately, to this, which is actually some of the flexibility that is offered when that patient goes on site to a clinic. The Wi-Fi, the technology is there to get those services at another remote site. Alrighty, you can move on to the next slide. I'm going to hand this over to Rhonda.
I had talked when we first started just about transitioning, from one level of care to the next. So we wanted to talk through just that process of transitioning from outpatient to intensive outpatient. That's something that we typically may see in our practice here at BrightView. Individuals coming into us and starting maybe on the outpatient level of care and, needing more intensive services to help them stabilize. And so when this transition occurs, this is not to be seen as a punitive measure in any way. This is a way of individualizing the treatment program for the patient or the individual so they're able, to deal with things that are going on in their lives and deal with barriers that are impacting their recovery or even their ability to engage in treatment. So patients that are suitable for this transition may be those, again, that are not making progress in the outpatient level of care. It may be due to, they've been coming in consistently, but for some reason, they're just not able to practice those skills that they're learning in treatment out in their daily lives. They may also have just higher levels of stress that are happening or environmental triggers. I mentioned to you, I think, an example of someone who has another person in their home or their family that is using substances. From experience, that can be one of the most stressful, things for an individual, and of course, make it difficult for them to maintain their recovery. And so we often see that, and of course, we may see that play out in terms of relapses continuing to happen, and that patient struggling in that regard. Individuals may also just need more medical support due to a psychiatric crisis. They may have mental health symptoms that they have escalated, or they're starting to manage those and they need just more support in doing so. And so we talked about that intensive outpatient level of care, meaning that the individual would go to, start coming into the center 3 days a week. So they're able to be, in person more than once a week. Right? Once a week is pretty common in outpatient, or even less sometimes. So if that person is in this crisis state or they have these increased symptoms, those touch points in person and that repetition during the week can really help them with skill building and, most importantly, helping them to stabilize. And so again, we may see this play out in terms of just the individual, not meeting the requirements that they've set up in their treatment plan. things just aren't progressing the way that they're wanting them to. And so these more intensive services give them the opportunity to eventually get back to that outpatient level of care, but most importantly, to stabilize. I'm pleased to say on the next slide, we have one of our therapists that has joined us today. She's actually in the room with Dr. McClain. This is Shanda Talent. She is one of our therapists. She's been leading our intensive outpatient program for a year or more now, right, Shanda? And Shanda is a LPCA and has been with us for several years. So Shanda, I will hand it over to you and you can share just some of your experiences.
Thank you. I appreciate the opportunity to speak. Intensive outpatient IOP, it can be a very vital part of a person's recovery. It teaches you how to live clean and sober. When you've come from years of addiction, you're not sure how to do anything anymore. You just don't know how to do it sober. So IOP teaches you that. What does it look like when your assessment places patients at the IOP level instead of the standard outpatient level? There are various reasons why patients are placed in IOP, but it's usually because they need more structure and support than outpatient care provides. After stabilizing and developing coping mechanisms in a social support group, they transition to the outpatient care. I have seen personally, people are able to build their support systems with their peers from IOP. They continue to help each other once they've completed the program. It is important to explain the reasons for the IOP referral to the patient and to help them understand this is a short-term level of care until they can work with the team to stabilize. Developing a treatment plan to address their specific needs and goals is very important in helping them transition to outpatient care eventually. It's very important that patients realize IOP is not a punishment. It is a form of treatment. Most patients are in IOP on an average of 6 to 8 weeks. IOP to outpatient, some success stories. The gift of group counseling, court-ordered IOP. The patient was initially very distant and did not want to be there. He was not receptive at all. He was worried about sharing in group counseling sessions, but realized he could just listen to others and learn from the group leader. After a few sessions, the patient realized how it was changing his life and participated. He eventually opened up, talking through his needs and getting support when he completed IOP. He was asked what was most helpful, and he said, "My new toolbox of tools that I use in my life daily." After 12 weeks, the patient transitioned back to outpatient care with weekly appointments and now comes in monthly. Another success story, this patient was referred to IOP due to chronic alcohol use. She had tried IOP twice in the past at 2 other providers, but did not complete successfully. This time she completed IOP after 7 weeks. And she stated, "I feel like I can keep this alcohol beat now." The patient shared that learning coping skills and when to use them was very helpful to her, and to be in a group with other people learning and doing the same. The patient has been able to transition back to outpatient level of care for weekly visits.
Shanda, I'm going to ask you a question.
Yes,
ma'am. You mentioned the first patient took 12 weeks.
He
to
did.
complete. This patient only took 7.
Yes.
So how do you differentiate when is that person's ready?
The patient that completed in 7 weeks has a support system outside of treatment. The first patient did not have a support system. He had to build that during his time, and he wasn't quite ready in the beginning. So it took him a little more time to grasp a hold and get interested in it and figure out that he did need to do what was asked of him. And so that's where your support system comes in as well. When you don't have a support system, it tends to take a little bit longer in IOP. But he learned, and he now has support from his fellow IOP outside of the group.
Great. Appreciate that insight.
Thank you.
All right.
That's
We can
great,
move
Shanda.
on to
Thank you
that.
for sharing those examples for us. And your, most importantly, your firsthand experience as you're leading the IOP each and every day. So we've reviewed with you just the different levels of care so far. Just a recap, we looked at, of course, inpatient treatment, intensive outpatient, and outpatient. And so we're going to talk just a bit now on how to determine level of care. That sounds pretty complicated, probably, just based on some of the things we've mentioned so far. And so first thing that I'd like to start with is just saying that the best way to determine level of care is for the individual that's needing treatment to work with a provider to get a thorough assessment. And we're going to talk about just what that assessment looks like and these different criteria for an assessment. So first and foremost there, it says acute intoxication withdrawal potential. So in thinking about the appropriate level of care, one of the things we'd look at here is just determining if their level, if their intoxication and their withdrawal was life threatening. Are they having seizures? Are they having periods of blackouts? Different, areas there that may be impacting their life that are more severe. The biomedical conditions and complications that may be associated. We mentioned some of the different dual diagnosis that a person may encounter, but also it's important to note here that just chronic illness should be factored in. Dr. McClain had mentioned about virtual programming, being really a helpful option for people if they were, having difficulty with their immune system or they'd had a surgery or something. So this will be factored in there as well, in terms of what their medical needs look like. And then Dr. McClain on this one, as far as just the medical evaluation, do you want to speak to just the component of the medication assisted treatment for just a minute as well?
Sure. So a patient generally may know the options available in regards to medication versus no medication. But during that medical evaluation, that's one of the things that we're going to talk through. And we're going to make sure that that patient understands all the options available. Typically, the patient will come in and kind of have an idea of what they want. For example, do they want buprenorphine product, which is commonly the brand name Suboxone, or are they more interested in methadone? Or if there's alcohol and underlying disorder, do they want a block or the naloxone or the Vivitrol or something along those lines? So as we're walking this patient through the options and looking at these 6 ASAM criteria, then we're going to be reviewing all those different possibilities and determining what the best route is. And one thing I do want to mention, the ASAM is the American Society of Addiction Medicine. And it's very, it's I guess the federal program that deals with addiction and really helps set these guidelines. So alrighty, move on there. Rhonda?
Yeah. So looking there at number 3, that's dimension 3. So we talked in dimension 2 there, number 2, about the biomedical conditions. So this is the area where we would assess to see what this individual's emotional needs look like, their behavioral needs, behavioral meaning their mental health issues they may be experiencing or symptoms, and then any cognitive conditions. Are there any learning deficits or disabilities there, or any of those factors or complications that we need to consider? And so most importantly, in thinking about dimension 3, we would look to just see what their mental health symptoms or those emotional symptoms that they're experiencing, what do those look like and how do they impact their daily functioning? And so that's one of the key areas there for determining the appropriate level of care. Simply put, an individual that is having more impact on their daily functioning may need a higher level of care. And so things like the inpatient that we looked at or the intensive outpatient may play in there. Dimension 4 looks at the individual's just readiness for change or treatment. Are they willing to seek help? And so that is an important area to consider just in terms of knowing what that individual's perspective is around what their problems or needs may look like. So you can imagine there, if a person has a lower readiness to change or limited insight on their problems, something like an inpatient program may seem pretty outlandish to them. So we would never make a decision based on just one of these dimensions. It would be a combination of looking at all of these and making the right assessment. Next slide. Last few sections here, the ASAM assessment criteria would be number 5 there, the relapse, continued use, or continued problem potential. Meaning, what does this individual's substance use look like on an ongoing basis? What's the potential for them to relapse and for this to create additional problems or ongoing issues in their life? And so that would be factored in here. And then lastly, we've talked a lot about sober supports and support at home or supports outside the home. So this really plays in here for dimension 6, number 6, recovery environment. So is this patient or person, do they have a safe place to live? That often is a factor of treatment for a lot of individuals that we see coming into our centers. We may have to start right there with helping them, find a safe or appropriate shelter. So that certainly has to be factored in. And then what does their environment look like? Who are they living around? Who are they interacting with on a daily basis? Is there any other person in their life who isn't using substances? And that question, you would be surprised at how often that may be no for many individuals, just from the standpoint that substance use does tend to be so familial. Usually if someone in the family is using, there's others in the family as well, a lot of times. Next slide. So we've talked about those ASAM level of care placement criteria there. We looked at those. And then just the same, one of the things I mentioned to you back on that slide at the beginning was just the importance of that individual or that person that you're looking for treatment for them collaborating with a licensed provider or program to make sure they get a thorough assessment. And so just as you saw on those ASAM criteria, that assessment really is two-part in terms of being both medical and then this biopsychosocial piece. And so the biopsychosocial piece, as Shanda mentioned, a lot of this, plays out in terms of the individual being able to still live in their daily lives and apply those skills in a safe manner. And so for us to help them in doing that, we have to assess to see, well, what the barriers are, in those areas. And so those different dimensions there include, again, their substance use, their withdrawal potential, what their medical needs may look like, their psychological needs, how ready are they for change or treatment, and then that recovery or living environment. And so this will be completed typically by a therapist as part of a biopsychosocial assessment. So important word there, that biopsychosocial. Addiction is something that impacts a person's whole life, right? Their overall well-being, the whole person. And so we want to make sure that that assessment is thorough, looking at those biological aspects, the psychological piece, and then that social environmental piece as well. Next slide. I'll hand it back to you, Dr. McClain, for this one.
So this is pretty easy here. We're looking at this great table that's comparing the programs that we've talked about. So on the left side, you've got your type of program, the inpatient, the IOP that Shanda mentioned and walked us through, and then the outpatient, either the on-site in-person or the virtual telehealth option. Then the length of the program is that second column, 30 days to 6 months, and that inpatient, a minimum of 6 weeks for the IOP, and as Rhonda had mentioned earlier, that's 9 hours per week, typically broken up over 3 days. The outpatient, both in-person and virtual, is as indicated, can be unlimited, and just as long as it takes. So approximate cost as you go down that column, the cost does decrease. So your most expensive typically is that inpatient. Next would be the IOP, and then the outpatient in-person versus the telehealth option. So on-site stay, obviously the inpatient, you're going to be on-site. The IOP, you can live at home. There are programs that you can reside there during the week, for example, and do some of this as well. And then the outpatient, both in-person and virtual, would be living at home generally. The severity of use disorder, typically your more severe unstable patients are those that we're going to recommend inpatient, that highest level of care, particularly some of those patients who may come in intoxicated, need acute medical supervised withdrawal, or more commonly known as detox. We're going to try to get those patients a bed and to have that medically supervised so that we have a better control idea and monitoring what's going on with them so we can keep them safe during this time. The IOP is your more moderate to severe, but we consider those perhaps a little bit more stable. Certainly they can be somewhat unstable, but as we progress down that column, we're hoping that that patient is becoming more stable. So your outpatient, both options are going to be any of those mild, moderate to severe, but typically more stable. Again, we do have some unstable patients, we would call them, that are choosing those options because the other two options just are not available to them for multiple different reasons. And we hear many of those. For example, they have to stay at home and take care of their elderly parents. They're afraid of losing their job. If they go inpatient, they're afraid of losing their apartment because of financial distress by not working. And many times it has to do with pets. They are not able to take their pets with them in an inpatient program, and so they choose not to do that. The last column is the other, and that looks at several different external factors. For example, triggers. It was mentioned the social aspect. This population is very vulnerable at the very beginning of treatment and throughout at times, and so would hope that being away from some of those triggers, other people using family members with secondary gain is going to be helpful. You would want to hopefully have them to be a captivated audience in an inpatient program if that is something that's interfering with their progression in recovery. The other programs, as you can see, you can walk down through there and read, but the IOP is for those patients who need a higher level of care, but either don't need that inpatient or are not able to do the inpatient for reasons that we've discussed. So the IOP is a middle ground. During that IOP, certainly other treatments can be being utilized, including medication-assisted treatment, counseling, etc. So finally, we've got the outpatient in-person and the virtual program. So with the outpatient in-person, the prescriptions are filled through basically a pharmacy. So we're sending that prescription in or writing a prescription. Typically now we do send that through the computer, and the option of opioid treatment program, which is commonly thought of as your methadone clinics. If that is an option, the medication can be dispensed on site. Kentucky calls the OTP NTP, narcotic treatment program, same thing as an OTP. In Kentucky, we do dispense, at BrightView here, we do dispense methadone and buprenorphine on site. So those are options. The final virtual telehealth option, typically that is done through the third-party pharmacies where the patient is seen by the provider through the video connection, and then the prescription is sent into the pharmacy. So those are some of the differences there. Alrighty, we can go on to the next slide. Which program is right? So we're taking, again, remember, one size doesn't fit all. We're looking at all different factors. We're talking to the patient. We're thinking about the best path of recovery for this. It's not the criteria that has to be fit in every category. Sometimes it's just not possible. So what are we looking for? Well, personal preference. We're going to talk to that patient. We're going to look at their comfort level, and are they interested in group therapy? Are they interested in telehealth? Are they interested in residential, staying somewhere, being more of a captivated audience in a very well-defined infrastructure and monitoring and being held accountable? So the other thing that we think about is, how's this substance use disorder impacting that patient's daily functioning? So again, we're going to look at their environmental issues. We're going to look at their job situation. We're going to look at their responsibilities at home and how are they dealing with it? Are they are we concerned, are they concerned about suicidal thoughts or harming themselves or others? So we're taking all those thoughts and considerations into factor when we're discussing the options. Finally, sometimes it does come down to the options regarding finances. Does the insurance cover inpatient? Does the insurance cover outpatient? If they do not have insurance, can we get them insurance? Can we work with them through case management and help them get insurance? If not, can we work on a private pay situation? What can we do to help them in this situation? Finally, the most important thing, and that's that last ask, is we have to involve the patient in that decision making. We're going to give them the options. We're going to make those recommendations, but in the end, it's going to be up to the patient. It's going to be very individualized in what they need and what they want to see in their recovery and what they call success. All righty, we can move on to the next slide. When we talk about substance use disorders, every one of us sitting here knows and has been affected by someone with a substance use disorder. Probably, you know, someone who has overdosed on opioids or some other substance, or has had complications from alcohol use disorder and has ended up passing and losing their life. And so when we think about some of these things, one of the things that certainly is involved and we have to consider is employed patients. So even if a patient has a very gainful employment, they're very functional in life, they are not in a situation to be inpatient, we have to look at what the options are. So everyone that has a substance use disorder has to go through these same questions, even the employed patient. So what do we think about, particularly with this population? So outpatient versus inpatient. Time concerns. When you're gainfully employed, one of the big obstacles is you're afraid to lose that job. You're afraid of the financial consequences, losing your apartment and that sort of thing. So we have to think about that. Confidentiality concerns. We have to keep that close to the patient as well, and reassure them that that they're confidential, you know, that their treatment is confidential. Typically the outpatient is going to be less cost as opposed to the inpatient or the IOP. And this is going to preserve for an employer the premiums across the insurance later. And for the employee, that's going to be a less cost as time goes on. Excitingly, organizations are recognizing that substance use disorders in the workforce is common and treatable. The treatments are beneficial both to the employee and the employer, and the patient's identity can be kept confidential in these treatment programs. So what is the benefit of consistent substance use disorder in the workplace? Well, the employee is more consistent with attendance and punctuality. They're no longer perhaps waking up with a hangover. They're no longer having to search for those drugs of choice to keep them from getting sick. They're just overall improved and more stable as they're being treated. The turnover for the employer is reduced, thus the economics can swing in the positive direction with offering treatment or supporting treatment for these patients. And treatment does consist of counseling typically, and we certainly recommend that. And that addresses underlying issues such as anger, stress management, trauma, prior trauma. Many of our patients have trauma throughout their life and early in life, leading to some of these difficulties, underlying anxiety, depression. So by being in consistent treatment, getting the treatment they need, individualizing that plan, medication if indicated, counseling, peer support, case management, wrapping our arms around that patient and providing the care increases the employee satisfaction, quality of life, and helps continue that progression in recovery and successfulness in all aspects of life, including relationships, family, and of course, work. All right, you can move on.
So we put together a few examples here for you of just what a couple of examples of potential individuals who are seeking treatment and kind of helping figure out their level of care. So let's look at patient X. Patient X is a 28-year-old female using opioids, heroin specifically, and prescription painkillers, and then also engaging in some binge drinking as well. Physical health, so no issues here other than nausea and vomiting. Mental health has some depression and recent suicidal ideation as well as an attempt. And so thinking about those ASAM dimensions that we talked about for determining level of care placement, those are some important details that we indicated here about these patients, potentially just to give you like some ideas of red flags to look for. So you'll see there on the mental health, right? This individual does have, it sounds like, some active symptoms of depression, evidenced by that recent suicide attempt. And then with their substance use, they're using more than one substance, opioids and of course, binge drinking as well. This person has a limited support system. They're estranged from their family members due to their addiction. And then they primarily are only associating with other people who are using substances or have substance use disorders as well. Their motivation for treatment is based on the fact that they express a desire to quit. They've just not been able to do that. And they've tried some outpatient treatment attempts. You'll see there they've completed 2 already. Their level of care, their level of functioning, they're struggling just to maintain their employment, which makes sense due to their addiction that's active and their mental health issues that we mentioned. In terms of safety concerns, they've had some recent overdose incidents. There was incidents of them engaging in some high-risk behaviors just to obtain the drugs that they're using. And then this individual also had 2 DUIs, so driving under the influence in the past year, which really helps us see that their alcohol use is impacting their daily life and their functioning, right? They're engaging in unsafe decision-making by, obviously, driving while they're, under the influence of alcohol. And then lastly, environmental factors there. They're living in a neighborhood where there's high drug availability. So in thinking about their support being limited, they're surrounded by people who are using, and then, there's lots of access to substances nearby where they live. So if we're thinking about this person's level of care recommendation, does anybody want to put in the chat what you think it might be? Would this person be more appropriate for inpatient, intensive outpatient, or outpatient? Yeah, inpatient, right? Next slide. So we, on the next slide here, we have, of course, inpatient is the preferred level of care for this person. And due to those things that I sort of flagged through the discussion for you. So their co-occurring disorder, their limited support, frequent overdoses, and they've tried outpatient twice and it's not been successful. Next slide, please. So we also have patient Y here for you as another example. This individual is a male. He's using alcohol, has moderate to severe use. He has pretty good physical health, no major medical complications due to alcohol use, but he does occasionally have some withdrawal symptoms where he's shaking, having anxiety. He's had some seizures in the past, even being admitted to the hospital when he tried to just stop drinking cold turkey. He does have some mental health needs as well, with a past history of an anxiety disorder. He has some stress and anxiety, and he does say that those things are attributed to his drinking. He does have some support system in place through his spouse and his 2 children. He also has a strong desire to cut down or quit his alcohol use. He's self-referred himself to outpatient. And his boss at work has even recommended him to start treatment. His previous treatment history there, he's had no previous formal treatment history. And the reason for that is due to concerns about stigma from his extended family. He's worried about what they'll think of him and what, if everyone finds out he's been in treatment, what they might think about his family, might ruin their reputation. Unfortunately, that concern is pretty common for the patients that we're serving. There's still just a bad stigma for substance use in general, and so that makes sense, definitely. His level of functioning, he's able to maintain his job. He's working remotely. He's also maintaining his family responsibilities. And he has also, had his boss that was tipped off about him drinking during the day. So red flag there. And then safety concerns, no alcohol related incidents. So no DUIs for this gentleman yet. And no legal issues. And then he also hasn't reported or shown any suicidal ideation or self-harm. And then lastly, looking at his environment, he's living in a pretty stable home and he's 30 minutes from the nearest treatment center. So any guesses there on what level of care he might be appropriate to start in? Yeah, next slide. So this gentleman could be appropriate for outpatient based on, the different things that we discussed on that previous slide. But most importantly, he is motivated. He's wanting to eliminate or cut back his alcohol use. He's also living close to a center. He has means to even support potentially, virtual services. So that could be an option for him also. Next slide.
Right, I'll pick up here. So program commonalities, we're going to kind of go through this because I want to leave a few minutes for questions here, but basically individualize everything that we've talked about. Look at all those factors that we've mentioned throughout. Does the patient want medication, and where can that patient get medication? Look at your inpatient programs. Is that an option? IOP, is that an option? And finally, your outpatient, go through those criteria that Rhonda went through. We're going to think about a relapse prevention plan as well. And then what's going to happen, discharge planning if that patient is inpatient out or IOP. So we're going to look at all those areas and come up with an individualized plan. All right, we can move on here. In the parting thoughts, Rhonda, you want to take on that?
Sure. So we've shared a lot of information. I was reminded of how much and how complicated this process can be in just determining the right level of care, and most importantly, trying to find the level of care that fits that patient's needs and where they're at in their life at the moment, right? And so just a reminder, in choosing the right addiction program, the most important thing there is to get input from not only the patient themselves, but also the addiction treatment specialist, healthcare professionals, getting that comprehensive assessment that we mentioned. I saw in the chat that someone said, why don't we just use the ASAM criteria? We do, right? The ASAM criteria is our guiding force in determining level of care, but it's still helpful to have a comprehensive assessment from both the side of medical and then also a clinical assessment as well. And then just tailoring the treatment approach to that patient's needs. And so I noticed in the chat, some people recommended different levels of care. And, it may be that patient starts in the least restrictive level of care, and then they may have to move up to a higher level of care if they're not making the progress, that they're wanting to make. And so it's definitely a process that requires ongoing review, collaboration between the patient, their support system, their family, and their treatment providers. Dr. McClain, do you want to add anything else there on parting thoughts?
Well, I think the most important take-home message is talk to the patient. What are they looking at as an option? What is their success story and their outcome? What do they see as their motivation and success? We have just a few minutes for some questions.
Excellent. Yes, we've got a really good one to start things out. It pertains to, the family support, employer support, community support of someone when they're in recovery is obviously critical. And this person is asking how we can, as professionals, prioritize, engaging and informing our patient support systems across these different areas. They've got, our patients typically have poorly developed skills, aren't trusted by their support system, which is understandable, but, we felt like educating them maybe on the addictive brain might be helpful. I guess this individual is just wondering if there's programs that involve their support system in treatment? And are there any other suggestions you guys might have on how to better engage a patient support system?
I'll touch on that, and then I'm sure Rhonda will have some things as well, Shanda, if we have time. But the most important thing is, what does the patient want? So this is very confidential. We cannot share anything with anyone without that patient's consent, and that's federally regulated and very, very important. So that's number one. What does the patient want? Who does the patient want to be involved in? I'm happy when I'm seeing a patient, have them bring their support person, have them come in the room. Let's talk about it. Let's share. And then, you know, we spent quite a bit of time on the IOP program, and then Shanda in particularly spoke about the need, the importance of that support system. So Rhonda, if you want to follow that up, and then we'll let Shanda maybe take a second.
Yeah, I would just echo everything that you just said. And I think, you know, what I've seen be most effective in working with folks is just to, you know, start with what they're comfortable with first. It may be them being agreeable to you talking to one person in their support system and helping educate them, or that person maybe joining the session or coming by the center to see where it is, you know, that they're coming for their services. And so really working with them at their level, and we do definitely want to support, you know, and expand that information to others, you know, in their circle for sure. But we want to do it, you know, with that patient's comfort level, and also being mindful that that typically can require quite a bit of education for people, and just understanding what addiction is, and also what that treatment journey can look like. So that would be my recommendation there. Shanda, do you have anything else to add?
I do. As a therapist, we work individually and in group on speaking and educating the patients about social supports. We work with case managers to have them help give them support where the local support meetings are. So I feel like as a whole team, treatment team, everyone touches base on that, and it's just educate, educate, educate.
That's great. That's all great stuff, guys. Yeah, I think I've got sort of two questions here. One's pretty straightforward, so I'm going to kind of combine them. But one individual's curious to know how we contact you for assessment, and also as it relates to methadone, someone's curious to know, how do they know if a center has methadone?
Sure, I can address that. So number one, how to contact, and you want to look at your community resources. If you're interested in BrightView and where BrightView is located, we have a great website with all the locations in the criteria, and they will define as well if it's an OTP, opioid treatment program. In Kentucky, it's NTP, narcotic treatment programs. Those programs are federally regulated, and that is the only way a program can offer methadone. Easy, call the center. You do want to make sure, if you're interested in methadone, that center does offer it. We do have patients that do show up at some of our centers that not all are NTPs or OTPs, and so they become very discouraged and upset that they did not realize that not all locations or clinics, and this is outside of BrightView as well, offer methadone. So very important. That's a great question. And unfortunately, there are not a lot of methadone treatment facilities. And it's very, very important to know what's available in your community or close by.
It's a great point, Cheryl. And it's also worth noting, as you can see on the screen, I also put a link in the chat to registration. But next month, we are talking about methadone, breaking down, you know, the science and the stigma of a often misunderstood treatment opportunity. So more to be coming on that for sure. In the meantime, one or two more questions we've got, including if someone wants to know if inpatient programs offer medication-assisted treatment.
Yeah, I'll start answering to that one. Some of them do. If they don't offer the medication-assisted treatment, they may allow the patient to still continue to receive that care from another provider. One of the things that we've run into quite a bit here at BrightView is that we will typically continue to provide that medication-assisted treatment while the patient goes over to inpatient care if that is a need that they have. So it's really based on the individual requirements of the program that you're looking at. Some may offer it, or if they don't, they may allow you to work with a partnership with another organization that does, like BrightView.
And one more question. If utilizing medication-assisted treatment, is weaning off of medication required?
I'll take that one. What we talk about during our visits is it's a collaborative partnership. Never do we force patients to wean off that vital medication that is keeping them off the streets and looking for their drug of choice. It's an individualized choice across the board, and there is no absolute mandated, you have to wean in 6 weeks, 8 weeks, 1 year, 6 years. No, the answer is it's very individualized. It's a partnership and a collaborative effort between the medical provider, the clinical services, such as their counselor, and certainly what the patient wants and needs and sees as their best outcome and success.
Okay. One more question. Do you utilize PMHNPs for any therapy in addition to medication management?
PMHP.
Sorry, I might have jumbled that a little bit. It's PMHNP. I don't know if maybe Amy could elaborate on her acronym for us. Psychiatric mental health nurse practitioners. Thank you.
Oh, lovely. I should know that because we absolutely have some of those. Sorry. We just call them psych NPs. But yes, sorry. Ideally, absolutely. Treating the comorbid, that dual diagnosis is so important in recovery. And our organization does support psych NPs as well. And many different other organizations do as well. And that is also an option outside of MAT. So say there's an organization that only does MAT with buprenorphine or methadone. Certainly those two can coexist and work very well together, and absolutely utilize that option. So sorry about that.
No problem. Yeah, we all learned something new today, right? Okay. Let's see. I think we might have one last one. Is IOP appropriate for someone transitioning from inpatient back to home?
We're going to turn that over to Shanda here.
Absolutely, IOP. When you're an inpatient, you're in four walls, you're secure, you're safe. When you're transitioning out of inpatient, you are going back out into the world, and IOP allows you to still have a safe haven, and then it teaches you how to live sober. When you're an inpatient, you're not doing everyday living, family get-togethers, work, community. So IOP will teach you and give you the tools for your toolbox that you need in order to succeed.
Okay, excellent. So I think that about wraps it up. Again, we'll be back here in November talking about methadone. There's a QR code up on the screen if you're interested. It's also in these slides. I dropped a link to the slides and certificate of attendance in the chat, so feel free to find it there as well. But if you need anything from us, let me know at marketing@brightviewhealth.com. Otherwise, we really appreciate everybody's time today. Thank you so much.